Hello. Today I'm going to share with you my experience of caring for patients on the Sick Kids 6AB unit who require enteral tube feeding, have ostomies, and I'm going to discuss how I assisted in performing stoma care. The table of contents for this presentation is that I'm going to first start by talking about enteral feeding tubes and pumps, the types of feed that we administer to the patients, how to perform a, gastric aspirate pH test to confirm the NG tube placement, how to assess the appearance of gastric contents, what an enteral tube emergency kit looks like, and what is gastric decompression and how to do that. And lastly, how to perform ostomy changes and stoma care. So, what is enteral tube feeding? Enteral tube feeding is a mode of delivery of medications and liquid food into the gastrointestinal system of a patient that does not require that patient to chew or swallow what is being ingested. These are some types of enteral feeding tubes. The NG and the G tubes are the most common. And sometimes it's a G and a GJ combination tube that you'll see, where I had one patient, their G port was connected to vent their stomach, but the GJ port was the one that was used for feeds and medication. I also see OG tubes sometimes, and these are used when the patient's nares are too small and an NG tube can potentially obstruct their breathing because babies breathe exclusively through their nose. So an oral tube is used in those situations. The gastrostomy tube, or G tube, is a tube that connects directly into the patient's stomach. It is radiologically and surgically inserted. The GJ tube is very similar to the G tube, except it's a little bit longer so that it can be threaded to the jejunum. And then a J tube is one that is surgically inserted directly into the jejunum. So it does not go into the stomach at all. These are some enteral feeding pumps. These are the two that I saw on the unit. One is delivering feeds through a syringe, and the other one delivers it through a bag, as displayed here. You must turn the syringe pump on a 45-degree angle so that the fats and the lipids rise to the top of the pump here. Sometimes, if you don't turn it on the 45-degree angle, the fats and the lipids can be trapped at the base of the syringe and don't end up being delivered to the patient. Here, I'm demonstrating how to manually prime feeds through a tube. Unfortunately, the video cannot play audio during this recorded presentation, so I leave it to your discretion to watch the video at a later time. You can access it using this link here or use the QR code. This is how you can use the Infinity Orange feed pump to feed your patients through the enteral tube. The feed pump's benefit is that it gives a very controlled rate at which the feed is delivered into the patient versus something called a gravity bag, where you use the clamp on the bag to control the rate of food delivery. However, that method is not as precise as when you use a pump. At the end of the feeding, don't forget to wash the bag with sterile water this bag with sterile water and prime the sterile water through the tubing and then hang the bag to dry. So let's go through the steps of how to use the Infinity Orange feed pump. So after we prime the feed through the tubing, we open the lid of the pump as shown here and connect the cassette of the feed tube system as shown here into the receptacle. Turn on the feed pump by holding the on-off button and then press prime to move the solution from the bag through the tubing if you have not already manually done so. You then press the food type. On our devices on the unit, it is always formula, even though you are using it to infuse express breast milk. It still just displays formula. You then press the volume and total button here to it will first show you how much has already been delivered through the pump. You can clear this value if you want to, so that when you are delivering this feed, you can see how much is delivered. You then press the volume button again to enter the volume of feed that you want to deliver using the plus and the minus keys. You then press the rate dose button to choose how fast the food moves into the patient. And then you press all three buttons one more time and then press the run button. On the display, it will show a cyclical icon just showing that the feed has started running. You can also hear that the pump will make a sound. Um, and that is how you will know that the feed has started. So the types of feed that we can find on our unit is, of course, the express breast milk provided by the parent of the patient. The parents leave this, and the express breast milk is sent to the diet office and it's brought back in pre-measured quantities. Sometimes the diet office will also fortify the breast milk with some formula, and then you will be infusing fortified EBM into the patient. It is always refrigerated and has a labeled expiry date because breast milk is very perishable. In contrast, the powder formulas such as Enfamil and Enfacare, they don't expire as fast, but you must limit the formula hang time to less than 2 hours because they do have perishable time once it is mixed with water. And then the ready to feed formulas are always sealed and they are sterile. And these would last a little bit longer, but you still need to discard within 24 hours of opening. They only last if they remain unopened. So why is it that we can only hang the feeds for 2 hours? The fats and the protein deposits build up in the feed equipment, such as the very thin tubes, causing blockages. Bacteria also can start growing in the feed system, especially in room temperature. And warming the feeds using the bottle warmer accelerates bacterial growth. So once a patient gets a new G tube, we need to check that G tube's placement. And then after that, we can be fairly assured that the G tube will not move, and we don't have to check for aspirate every single time we access the G tube. So after the G tube insertion, we expect to see that the feeds administered are tolerated by the patient and there's minimal bleeding. Or if there is blood, it's very dried old blood. We check the pH on the initial use and we expect that it will show less than 5.5. If the pH shows greater than 6, we have to use our nursing judgment to consider other factors, such as if the patient is taking proton pump inhibitors like omeprazole or lansoprazole, and if what we aspirated is the feed or the food. Formula usually has a much higher pH than the gastric acids. On the next few slides, I'll show what normal and abnormal gastric contents look like. So if the G tube is not tolerated by the patient, you would see there's worsening feed intolerance and some pain that is unrelated to granulation tissue that may have grown in the area. You'll also see excessive bleeding rather than minimal or old blood. And also, the pH is greater than 6. And if it's not greater than 6 because of these reasons, it could be that the G tube has migrated and is not sitting inside the stomach. So, how do we obtain gastric aspirate from a G or an NG tube? It's up to the nurse's preference whether to use a 3 ml or a 5 ml enteral feeding syringe. Sometimes some nurses have told me the 3 mil is a bit creates too much suction, and some patients don't like that. Whereas the 5 mil syringe is a little bit better, but it's up to your discretion. It's reminded, please don't prime the tubing because the water in the tubing can actually change the pH test results and also change the appearance of the gastric aspirate. Please pull back slowly for gastric contents not to damage the lining of the stomach wall. Sometimes the aspirate doesn't come very easily because the G tube or the NG tube end can be stuck to the stomach wall. So it's okay to push a little bit of air into the patient's stomach and then draw back quickly to try to dislodge the tube from the stomach wall. But we also need to be mindful not to push in too much air because that can cause stomach distension and bloating, which is uncomfortable for the patient. If there is still no aspirate, we can sit the client up and gently pat their back or have them sit and rock them a little bit from side to side, front to back to try to move the tube inside their stomach to a different location. In the case of GJ or J tubes, unfortunately, we cannot use the gastric aspirate method to confirm placement, so their placement is confirmed in the IGT, imaging under fluoroscopy. Okay, so how do we test the gastric pH to confirm NG tube placement? NG tube placements needs to be tested every time you want to access the NG tube, whereas for the G tube, only the initial time, and we can be sure that it did not migrate. This is also another video of how to check the gastric aspirate pH. I demonstrate it with an NG tube, and I also have my pH indicator strips. You may also watch this video at a later time. So this is the slides that show the appearance of normal versus abnormal gastric contents. The normal gastric contents should have a pH of about 1 to 5.5. It is abnormal if it's 6 plus because there is a chance of incorrect tube placement if we see that the pH is too high. The color should be clear and the consistency mucous, or you could see a bit of yellow or sometimes green. However, the abnormal appearance is brown or blood tinged. We don't want any blood in the gastric contents. So like here are some examples: light brown mucousy cloudy, gastric aspirate. You can see this one is the partially digested formula. So I would expect that the pH of this aspirate is going to be higher, and that should still be normal. And this is clear with a little bit of green with some sediments. This is also undigested formula, so I'm also expecting that this would be higher pH. This one not as high as the fully undigested formula, but still high, whereas this could possibly only be gastric contents, so I would expect that to be lower. And this is examples of abnormal gastric aspirate, where you can see there are streaks of blood. It's a little bit brown and a little bit blood tinged. Especially if you see excessive bleeding. This is very abnormal. So, in every patient's room that has a patient who has a G tube, we should have an enteral tube emergency kit. For patients with NG tubes, we don't need this kit because a nurse or another healthcare professional who is qualified could just reinsert another NG tube and check for aspirate and placement location if needed. But for the G tubes, it's a surgical procedure. And as nurses, we want to make sure that the stoma that the G tube goes through does not close or does not stenose, which means that the opening becomes much more narrow. So we want to make sure to get that Foley catheter into that stoma as quickly as possible and to keep it open with a little bit of lubrication and then get that patient into surgery ASAP. Now I'm going to talk about relieving gastric pressure during feedings, which is also known as gastric decompression or enteral decompression. The sick kids uses the feral valve system with a feral bag. So I'll go through the steps of how this works. First, we hang the feral bag above the IV pump. Usually it's in parallel or a little bit higher than the feed bag. We have to make sure that the Y port of the feral bag sits below the patient's stomach. You have the feral bag, the pump, the stomach, and then the Y port. You must close the clamp on the feral tubing before you attach it to the patient. And then you connect the feed pump's tube to the port on the feral tubing. And then you prime the feed through the lower half of the feral bag until you reach about 1 inch or 3 centimeters away from the patient's stomach. This ensures that this length of air in the tubing, the diagram shows a much shorter length than is actually in the vent in the feral bag. It's actually quite a long bit of tubing here. So that's a lot of air that you'll be pushing into the patient if you didn't prime the feed through this tubing first. Okay, and then you connect the feral tubing to the patient's feed port, and you open the blue clamp, you open the patient's clamp, you open the clamp on the upper white roller clamp, and now everything is unclamped and the feral system is ready to use. So here I'm just demonstrating in the video the feral bag and the feed bag and how to attach everything. Please watch at a later time. Now I'm going to discuss ostomy care. So the sad thing with ostomy appliances is that no matter how long you take to stick this appliance onto the patient, sometimes it still leaks. So sometimes you're changing the ostomy bag more often than you initially anticipated. So what is an ostomy? Well, it's a surgically created opening from the bowel or from the urinary bladder or the urinary tract through the abdomen to the outside that directly drains stool or urine out of the body from the small or large intestine or the bladder. A stoma is this little pink area that is at the end of the bowel or end of the ureter that protrudes through the abdominal wall. A healthy stoma looks red, pink, and moist. Since there's no nerve endings, when it's touched, it does not cause any pain to the patient. The ostomy appliance is this bag here with this attached to the patient. It collects the fecal or urinary drainage and protects the skin that surrounds the stoma from this fecal matter and urine because this is very irritating to the skin and can cause skin breakdown. So we always empty the pouch and stoma bag when it is about 1/3 full, again to decrease the chance of leaks. And also patients can bathe with the stoma bag on or off. It is fine. So when you start your stoma care, there's some equipment you want to have next to you in the room. Some washcloths and towels, a disposable protective pad or a blue absorbent pad because it can get quite messy. Non-oily soap if you think it's necessary to clean the area around the stoma prior to sticking the stoma appliance on. The scissors is needed to cut the stoma appliance hole to make it the size of the stoma on the patient. You have a little measuring guide. Sometimes you want to see if the stoma has changed size, and also to help you cut the hole. You want to have your new stoma appliance and a paste to create a barrier around the appliance and the skin, just as an adhesive to prevent leakage. And then you want the Kevlar skin barrier wipes that creates a little bit of stickiness when you stick the appliance down. So first you need to wash your hands and put on some clean gloves. Place the absorbent pad under the patient to protect the, the linens and the bedding, as well as the patient's clothes from the stoma exudates because the stoma is still working when you're doing all these changes. Sometimes it's good to have somebody just hold a sterile gauze over the stoma during this process so that the stoma doesn't leak over the skin that you had just cleaned in preparation to stick on the appliance. So then you remove the old stoma appliance and discard it. Peel it softly and carefully if it's still sticking to the patient. And you wash the stoma with a soft washcloth, a little bit of non-oily soap and water. Sometimes there's a little bit of bleeding, and that's normal. And then you just rinse it and pat it dry. You want to take this opportunity to assess your stoma without the appliance covering it. It should be red or pink and moist and firm and project about 0.5 to 2 centimeters above the skin level. The peristoma area should be slightly pink and it shouldn't have any granulation tissue. You want to measure your stoma and cut out that circle and make sure that the cut opening is at least 1/8 inch bigger than the measured stoma size because if you rub against the stoma, it could irritate it and cause the cells there to die or cause granulation tissue to form. You apply the paste around the stoma and then press the adhesive side down on the appliance on the skin around the stoma. Make sure that the skin is clean and dry before applying the appliance and that there's no wrinkles under the skin barrier. Then you add the pouch on top of the appliance that's stuck to the skin. Remove your gloves, perform hand washing, and then make sure you document your care and your assessments. Okay, so that's it. Thank you very much for watching and listening.